everybody. I'm very happy to welcome you to this symposium driven by MSD on Women and HIV, a path thrown with challenges, tailoring prevention and treatment through the lives. I'm Karine Lacombe, infectious disease specialist from Paris, and I'm going to be your chair for this symposium. So this is the declaration of interest. First of all, I would like to present the agenda to you. So we're going to have 3 speakers, including me. The first speaker will talk about Don't Leave Women Behind on the Path to Prevention, and it's going to be Elizabeth Boccuzzi addressing this issue. And I will talk about the keys to driving pregnancies with confidence in 2021. And then the third session will be driven by Claudia Cortes on how to better support the long road of postmenopause. And then we will have a question and answer session. So first of all, I would like to turn the mic to Elizabeth Boccuzzi, who's going to talk to us about not leaving women behind on the path to prevention.
In the next few minutes, I hope to be able to share my thoughts with you on how and why we should include women in prevention research. I'd like to thank the organizers for this opportunity to be able to share my thoughts. I do serve on several expert boards with public service, but I also have been a speaker for MSD, and I've also served as an expert for Gilead in several symposiums. We've come a long way from doing research, from the days when people did experiments with products that had uncertain content, and there was no clarity in what the outcome would be. There was lack of consent, and people often experimented on themselves. They also did not always provide information to the subjects of what to expect. Now, we have a systematic way of being able to, first of all, test plausibility, to ensure that we are minimizing any side effects and that products are safe before we actually test them, and go into efficacy to try and ensure that we can improve the lives of individuals because of doing research. Women were often left out in the early years of research. And this was partly because there wasn't a clear understanding that there was very distinct differences between men and women. There were also concerns about reproduction, that women could be pregnant, and we didn't have very efficient mechanisms of preventing conception. There was also concern that even when we prevented conception, they may interact with the product that we were testing. There was also a challenge that what if women were pregnant? What would the product effect be on the unborn child? Access to women was also another challenge because often people accessed men in the workplace or in the industrial areas in which they were available. Women often worked at home, and it was difficult to access them. Another concern was that of autonomy. Who made the decision for someone to get involved in research? Who made decisions about their bodies and whether to engage in research at all? Now, when I talk about women, I want you to think about them in all their diversity. This could be with regards to age, the workplace, culture, their sexual orientation. Could they be a stay-at-home mom? Could they be working in the corporate world? Could they be in school? Might they be pregnant? Might they be postmenopausal? A whole variety, large diversity when we think about women. And whatever we're thinking about and whatever we're testing needs to work for them. So the question might be, why should we include women anyway? Well, it is important because women do need these prevention options, and the current options are not always adequate and do not always work for them. We need to recognize the vulnerability of women in the different cycles of life that they're in. We need to make sure that this fits in with their lifestyle. with their circumstances. And we also need to remember that they're changing aspects of women's lives as they go through their life cycle. What may work for a high school student who's in a developing world may not work for a woman who's living in a remote fishing village, who may even be in a polygamous union, despite the fact that some aspects of their biology may be very similar. The culture, the social status, whether they're adolescent or lactating, all these may make a difference as to whether this product would be useful for them. I want to turn our attention to literacy because it's important. Please remember that literacy has nothing to do with intelligence. It's got to do with exposure, with the opportunity to understand the world around you, with the opportunity to learn to read and understand what's going on in the world. Sadly, literacy among women falls low, below that of men. And in sub-Saharan Africa, the area hardest hit by HIV, it's particularly low. In some countries and in some areas, as low as 20%. When we're thinking about research, literacy is important. And you might ask, how so? Because it makes a difference as to whether someone is able to understand enough to make choices and decisions. And culture also plays a difference and also adds to the challenge. What are the expectations of everybody, of the women? What are the expectations of the women themselves, of themselves, and what they are able or not able to do? I want to dwell a little bit on the issue of cultural competency. You know, when you think about the risk and the fact that women can be at risk, it's important for them to be able to make choices about their engagement in research. So how does culture and cultural competency fall into this? It's important that the innovative products and the opportunities we are thinking of can work for the women. But in order to engage in research, these individuals need to be able to provide consent. They need to understand they are engaged in a research process. Are they making the decisions by themselves? Do they need to consult others so that they can make an informed choice? And what does this choice mean for them and for those around them? Is it a community that needs to understand so that people can be involved? Are we ensuring that they have the privacy to be able to engage appropriately? And do we ensure that we have mechanisms of confidentiality, that risk-benefit analysis is clear, and we provide them with the supportive mechanisms that enable them to engage in the research from the beginning to the end? Ultimately, the research should empower not just the individual, but also their community as they engage in the process. I have just a few minutes left, but I want to say two things that I think are important for me. It's really important for the process of research when we're thinking about prevention that we provide options that are inclusive of women, as we talked about, in all their diversity, but also that there is empowerment of the individual and also of the community, that we're providing them with choices that allow them to engage, but also providing them with choices that will enable them to be able to utilize that product if it is found to be successful and can be useful in the armament of the work that we are doing. As I end, I want to think about Mount Kenya, which is the highest mountain in my country. I first climbed this mountain 20 years ago, and a lot has changed about it. Global warming has resulted in the snow that was on the peak having melted. One can still climb Mount Kenya, hopefully safely, but one needs to rethink how you get to the top and how you achieve your goals. And I think this is the same for the prevention work that we are doing. That there are ways in which we need to be able to do this work to ensure we can do it appropriately and be able to take the various steps that ensure the communities that most need those innovations and need that prevention are able to get it, but to do that they're able to be part of the research so that the solution is appropriate and meets their needs in the best possible way. Meaningful engagement that leads to empowerment but is inclusive is very important. And for this reason, we must include women in prevention research. Thank you very much for this opportunity to share my thoughts with you. It's now my great pleasure to introduce Karine Lacombe, who's going to talk to us about the keys to driving pregnancies with confidence in 2021.
Okay, thank you, Elizabeth. I will now address the issue of the keys to driving pregnancies with confidence in 2021. Here are my conflicts of interest. First of all, I would like to set up the scene by reminding you that in 2020, females from the age of 15 to 49 represented almost 50% of the total of HIV new infections across the continent. When focusing on Europe, they represented 1/3 of the new infections in Eastern Europe and 1/5 in Western Europe, constituting a pool of young women for which contraception and pregnancy were two issues very much intricated. Alongside the continuum of care for pregnant women, I have identified 4 challenges that I would like to address during this talk. First, of how to prevent unplanned pregnancies, and then how to keep viral load undetectable throughout the pregnancy. Then how can we manage the drug-drug interactions between contraceptives, for example, or the drug during pregnancies with ARVs, and then how to have a safe pregnancy for healthy infants. So when talking about the unplanned pregnancy, we have to bear in mind that this is a reality. And for example, in Africa, in South Africa, from this cohort study, we saw that there was a high rate of unplanned pregnancy in the context of integrated family planning and HIV care services. And in these 3 largest hospitals in Eastern Cape province in South Africa, 71% declared an unplanned pregnancy. If we go to the Western world, and especially in the USA, here again, we saw that among more than 1,000 pregnancies from 671 HIV positive American women, a very high rate of unplanned pregnancy has been reported, as high as 78%. When talking now about how to avert undesired pregnancy, the study that I show you here has been recently published, and is reporting data from the modeling through the analysis of multiple databases worldwide, and the number of children of infant HIV infection averted by contraception is reported here, as well as the number of infant HIV infection that could have been averted if unintended birth could have been prevented through contraception. And you see here that the rate of contraception failure is quite high in countries using pills or condom, and quite low in countries using intrauterine device or implants. And the number of pregnancies currently averted by contraception is about 56% in untreated HIV-infected women, whereas the number of unintended births that could have been prevented but were not prevented in fact because of the absence of contraception was a rate of 14% of all births, and almost 45,000 infections were due to unintended pregnancies, and mainly from women, not an ARV. So you see that there's this undesired pregnancy is a real challenge in HIV-infected women. The second important issue to talk about is the contraception and ARV and drug-drug interaction between contraceptions and ARVs. The prevalence of drug-drug interactions have been estimated to reach almost 20% in a cohort set in the USA, and mainly due to boosted ARVs, including cobicistat. And of note, 54% of women were using a non-hormonal device. However, drug-drug interactions are not only seen with hormonal pills, but also with other devices such as intravaginal rings. And in this randomized trial that you see here, it has been 3 arms have been compared: a norm without treatment, a norm with efavirenz-based, and a norm with atazanavir-based ARV regimen. And we saw that there was a decrease in EEO by more than 60% in women treated with efavirenz, whereas there was an increase in EEO by 71% of etonostrogel, and a decrease by 38% of etinolostradiol in women treated with atazanavir. So all these are risk factors for contraceptive failure or side effects. And you can see here from this chart that approximately 50% of ARVs lead to a risk of drug-drug interactions with contraceptives, and the only drug without expected DDIs being doravirine and rilpivirine, integrase inhibitors, except when boosted with cobicistat and, of course, NUCs. The pregnancy now, the pregnancy itself is a period of high risk of HIV infection, and I wanted to remind you the numbers that have been reported of the rate of HIV acquisition per condomless sex act. And you see that in the early pregnancy through postpartum period, the risk is very high, up to 2.76, and it's mainly seen during the late pregnancy and postpartum period. Switching now to being pregnant while HIV infected, I wanted to share with you the little data on ARV safety and efficacy in pregnant women. Looking back at into 2020 at data that feed the guidelines, I got an update on the CEPAMO study at the last IIS conference, and we also got the final data on the RALPHE trial. So first of all, the CEPAMO update gave us the prevalence of neural tube defect by ART regimen, and we saw that there is a persistence of a weak excess of risk of NTDs in women treated with dolutegravir at conception. Although this is a weaker than previously stated, this is still significant. And if we switch to the NRS RALPHE trial, which is a pharmacokinetic study of raltegravir during pregnancy, the final results show a decrease of the free fraction of raltegravir by 16%, and that's why there is no need for adjustment of raltegravir concentration at the third trimester. Finally, at CROI, the Dolphin 2 results at 72 weeks postpartum were released, as well as the IMPACT results. The Dolphin 2 results show us that the virological failure rate was 2.4% for the dolutegravir arm versus 6.4% with efavirenz. We saw 3 transmissions of HIV to infants in the dolutegravir arm versus 1 in the efavirenz arm, despite a controlled HIV RNA. And there was a slightly more adverse events in the dolutegravir arm. Regarding now the impact of the final result of IMPACT, a similar safety was noted through the 3 arms, whereas there was a similar rate of controlled viral load at the end of pregnancy, and we saw a little more weight loss with efavirenz. So what are the ART not recommended during pregnancy? Well, here again, dolutegravir, because of a higher risk of neural tube defect, if used pre-conception, so women should be switched to another drug. And here again, you see the list of antiretroviral drugs not recommended in women who become pregnant while on ART. Raltegravir QD is not recommended because of insufficient data about safety and efficacy in pregnancy. Same for bictegravir and same for doravirine. And for the other drugs, you have to be very careful about the possibility of having a lower level of drugs between the second and third trimester, and especially with drugs boosted with cobicistat. So what to start with during pregnancy? Well, there are a few options based on dolutegravir, but you have to again remember that dolutegravir is not recommended in the first 8 weeks of pregnancy, and women should be HLA 57 negative, as well as HBsAg negative if you want to use a 2DR regimen. You see here that when PI is used, it should not be boosted by cobicistat, as I told you a little bit earlier. And just to highlight the fact that regarding the raltegravir during pregnancy, we got an update of the first trimester prospective exposure, and you see that more than 1,000 pregnancies have been recorded with an exposure to raltegravir during the first trimester, and this led to 1,068 outcomes. And because there was no safety signal regarding the babies and the safety for the babies, raltegravir has got an expansion of the label to pregnant women in Europe, and it's expected to be possible in July to 2029. So in summary, driving a pregnancy in confidence in 2021 should first avoid any situation of undesired pregnancies, and the choice of contraception and prevention of drug-drug interaction with antiretroviral therapy is part of the process towards pregnancy. And finally, avoiding DDIs that could lead to a detectable HIV RNA is a key element of a safe pregnancy and a delivery leading to a birth of a healthy baby. Thank you very much for your attention. I would like to turn the mic to Claudia Cortez now, that will address the issue on how to better support the long road of postmenopause.
Hello, good morning, good afternoon, good evening. I'm Claudia Cortez. I am Associate Professor from the University of Chile. It's an honor to be here talking about something else, not COVID. We're in the middle of a second surge here, has been terrible and worse than the first one. So talking about something else, it's happy now. So how to better support the long road of postmenopause women, that is what we're going to talk about. These are my disclaimer. And what we should care of in women. We should care about HIV diagnosis that should be available for every single woman who need it. HIV treatment, effective, safe, and affordable drugs for everybody. HIV prevention, PrEP, female condom, PEP, or any other way to prevent HIV. Dignity, zero discrimination, and zero stigma. And I put happiness because I truly believe it doesn't matter if we have a patient with undetectable viral load and high CD4, if she cannot fulfill as a person and do whatever she wants to do to feel complete. And also we need to pay attention to general health. Our HIV positive women don't only have HIV related issues, they have other diseases. And if you are 50 or more years old and you have HIV, you have many concerns, and if you don't have HIV, you also have those concerns. But focusing our HIV patients, I am denied HIV treatment in some places. That could be the how it's going on. No one listened to my concerns. I fear being a burden. I am ignored by younger people. You can read here, and there are many concerns in women older than 50 years old. And what question we should ask of ourselves as physicians and as people who is treating HIV women. Is the person, these women, functional, mobile, and pain-free as possible? Are we taking care of all those things, or we are only taking care about viral load? Do disease management choice reflect the person's priorities? Are we giving the patient what she wants and what she needs, or what we want, and I decide for the person? Is this person taking the correct dose of the correct medication? There are many interactions. Older women take more medication, so the possibilities to have a drug-drug interaction, if you have a high polypharmacy, it's higher, that possibility. And has the person mental issues, both affective and cognitive? Are we treating them? Are we looking at them? So what happens when you are experiencing menopause and HIV at the same time? You have uncertainties because you don't know, this is new for this person. Is there going to be the same symptoms? It's going to be different. I'm going to have a more early menopause, or it's going to be later. I'm going to have more symptoms. We really don't know, or the patient really don't know. I have a lot of concerns about that. There are consequences. There are drug interaction between hormone replacement treatment and antiretrovirals or antidepressants that women, especially women with HIV, take in a considerable amount, or any supplemental diet. And of course the comorbidities that are appearing across the age, and some of them are osteoporosis, cardiovascular risk, mental health, or others. And I did what I do all the time. I look in PubMed and put this very simple words, HIV in adults and girls, and you can see this huge number of publications. Then HIV in women, a little bit less. That's curious because adults and girls are women. And HIV in pregnancy, 21,000 publications. And then look at here, I have to make a change in the scale because if you put HIV in menopause, 340. HIV in older woman or postmenopause, HIV 250, and HIV in postmenopause, just 80 publications. So it seems that really nobody cares about this topic. So do really exist older women with HIV? Yes, they do. And they are more distributed in different ways than younger people. So what's the number? In 2019, there were 19 million of women living with HIV 15 years or older. 55% of them were between 15 and 49 years old, and 13% were 50 years or older. And 2/3 of these women that are 50 years or older live in Europe and North America. And you can see here this in numbers, and you can see how the numbers in low and middle income countries where go around 2016, what the publication was done, around 4 million, and they estimate for 2020 about 6 million. And then here in high income countries, the number is less because we know the HIV epidemic is a little bit lower in terms of numbers in high developed countries. But then you go to proportion, it's invert, and here you can see in high middle income countries, it's estimated that 35% of population is 50 years or older for this year or last year. So menopause, that's not the only thing that we should care about, but menopause is something very important in the vital life of women. Drop in estrogen levels. This increased morbidity secondary to changes in postmenopause, cardiovascular, microvascular, skeletal, and immune system. And you can see that menopause may present at younger age in women with HIV. So as physicians, and healthcare workers, we should be aware, so we start doing the diagnosis and the treatment early. And women with HIV have to have a higher risk of cognitive impairment, so we should also take care of that. And many of us, we don't have the training to take care about this, so we should ask for help. So what we should pay attention, and here I put 3 things that we are usually not paying attention because it's not our area of knowledge. We know about infectious disease and HIV and virus, but what happened with the neuropsychiatric area of concern of our patients, or substance abuse, or intimate partner violence? That is very important. Going to neuropsychiatric, HIV-infected older adults are more likely to have more depressed symptoms, suicidal ideation, AIDS-related stigma, and comorbidity. HIV has been well documented to have direct effects on CNS, and with a wide range of neurocognitive symptoms ranging from minor cognitive disorders to dementia. So it's something we need to take attention. And substance abuse in general population of older women, it has been estimated approximately 10% of older women use drugs and alcohol. And intimate partner violence is a factor to be considered when assessing the role of relationship in HIV risk. APV has been associated with greater risk of HIV, and overall, women with HIV has higher likelihood of having experienced IPV. And then we can go to these more classic and very well-known things that we should pay attention as cardiovascular risk, hormones, and musculoskeletal. Of course, women, as they getting older, they have more comorbidities, and they usually come with age. Not all of them, but many of them. Hypertension, diabetes, COPD, cancer, pain, a different kind of pain, thrombotic disease, dyslipidemia, Parkinson's disease, anxiety and insomnia, Alzheimer's, and menopause. But menopause as only one of these lists of diseases or comorbidities or states. It's not the only one we should pay attention. And then depression, insomnia, and HIV, this is highly prevalent. It's the most common neuropsychiatric complication in people living with HIV and may occur in any phase, but you can see that if you're getting older, the chances of having a depression go high. Compared to general population and compared with HIV seronegative, the prevalence of depression is 2 to 4 times higher in people living with HIV. And in general population, gender is always a risk factor, and as we know, women have higher risk of depression. Here is a very interesting publication about mental health in HIV, specifically in women, and you can see that this depression can go to more severe HIV-related symptomatology or lower adherence to treatment. The same with PTSD, also drives to low T cells counts, or anxiety, again with disease progression and worse quality of life. So everything is interconnected. And antidepressants and anxiolytics is one of the most used drugs in our patients, in our women patients. And here from the Liverpool University, you can see this table. Of course, as you know, red are very severe interaction, orange and yellow you have to pay attention, and the greens are more safe. Doravirine here, dolutegravir and raltegravir are drugs that are most safe with almost all antidepressants. Pay attention specifically to efavirenz, that is still very used in developing world and have severe interaction and should be not used in patients with psychiatric disease. And also there are many reports about dolutegravir that raise the suicidal ideation. What else we have to pay attention? Polypharmacy, drug-drug interactions, severe adverse effects, and adherence issues. And in HIV related, we have to see HIV aging antiretrovirals. There's a cumulative antiretroviral toxicity after many years of using this. This is a pro-atherogenic state inducing chronic inflammation. Lifestyle, women usually are getting older, they do less exercise, they start to be more obese, and there's also this vascular age increase. This fantastic diagram for Liverpool again says how we should take attention to polypharmacy and PK/PD interactions, and we should ask ourselves, is the indication correct? Is this medication appropriate for elder people? Is the dose correct? Should I need to adjust for renal function? Is there a significant drug interaction? Is there a significant drug disease interaction, for example, delirium in older patients? Is the treatment acceptable? Is there missing medication that should add? Or is the patient able to manage his or her own medication or did need assistance? So we need to take care about many things in older women. And here is a very interesting slide that I stole from Dr. David Buck in our last Real CROI. And they ask in several cohort how many patients take at least 5 drugs, non-counting antiretroviral. And you can see the huge number of patients that takes a lot of drugs. So the recommendation, training in healthcare providers, communication and awareness, we should take attention to all these comorbidities or situations that we are not used to, supporting adherence, menopause, the treatment issues, strengthening up support networks, evaluate neuropsychiatric changes, of course, all the comorbidities the patient could have, research agendas and policy guidelines. How to close the gap, early HIV detection and treatment, integration of services, psychological and medical support, social protection and trial participation, research, so we can know what is going on with our older women. Clinical programs for people with HIV must prepare to screen for and take care of aging-related problems that we are usually not used to do, begin to screen cognitive loss, false risk, that's something that we really don't care usually, and other aging-related complications. Ask for help. If you are not the expert, ask other colleagues that can help you. Screening protocols should include types of people to be targeted, when screening should take place and by whom, and referrals or other outcome of the screening. So this is my message, and thank you very much.
Okay, great. Thank you, Claudia. That was a great talk, and thank you, Elizabeth, as well. I'm very proud now to lead this Q&A session with women professors about women living with HIV. So we've got a bunch of very interesting questions. I would like to start with you, Elizabeth. We've got a question regarding the use of antiretroviral for PrEP in women. In terms of drug, what are the remaining needs to improve PrEP in women? And in other words, according to you, Why is Truvada not enough in the context of women?
Thank you very much for that question, Karine. You know, when we think about women, and I want to take it to the contraceptive world first, we have not got a perfect contraception yet because there's nothing that works for all women all the time, everywhere. This is the same thing. Yes, we do have oral PrEP that works, but not all women can take a pill every single day for the rest of their lives. We need other options. We need the rings. We need maybe a pill that one takes just once a month. We need an injection, perhaps, that one takes discreetly, and then they don't need to take something else for another month or even 3 months. So we don't have anything that works perfectly for women right now. Adherence is a challenge. Consistency and just being able to stay on the drug every single day is a challenge. So we need long-acting methods. We do need other options that are not just pills, maybe implants, injections. So I would say we haven't done enough yet. We need more options to allow women to choose something that works for them at whatever stage they're at in life and whatever circumstances they may find themselves in. Back to you, Karine.
Yeah, I completely agree with you. I think that we have to keep in mind that women have a very specific pharmacokinetics for antiretrovirals. And we know that when there is an adherence issue, as you just said, with Truvada, for example, if the woman stopped the treatment, it's not like in men when they can resume the treatment and be protected within 24 hours of use. For women, it takes a week to have enough Truvada in the blood and especially in the genital area to have this preventative effect of treatment. That's why it's very important to invest in other means of PrEP for women besides Truvada. Okay, great. Thank you. And I have a specific question for you, Claudia. Knowing the fact that there is no increase in bone fracture with tenofovir without booster, and knowing the fact that you have highlighted the cardiovascular risk in postmenopausal women, would you prefer TDF over tenofovir lafenamide in this setting? This is a bit tricky.
Sorry, I don't hear you very well, the last part, the real question.
Okay.
Sorry.
Well, you know that there is no increase in bone fracture with tenofovir disoproxil without booster, and you probably remember this meta-analysis from Andrew Hill and the data from Dominic Costagliola. And knowing the fact that you have highlighted the cardiovascular risk in postmenopausal women, would you prefer tenofovir disoproxil or over tenofovir lafenamide in the setting of older women? Or do you think that it's not an issue at all?
Oh, I believe tenofovir is a risk factor, but it's not a big risk factor. And we have to think the difference in price and TDF and TAP. So in a big part of the world population, TAP is extremely more expensive than TDF. So if your option is having treatment versus not having treatment or having drug that are, abacavir that you need to test before. So of course I will prefer TDF instead of not having TAP, for example. But the risk factors, the cardiovascular risk factors are much more present in users of protein inhibitors, as we already know. And that's one of the things that we should take into account when you choose your treatment.
Okay. And then I got a question probably for myself. Many women become pregnant on dolutegravir. And this is Caroline IB Pop from Switzerland. Hello, Caroline. And you think that you're not convinced that that we should not switch them in early pregnancy. Do you agree? So that's a question you ask myself, but I think that we can all answer this very important question. I think that personally, when I have a woman living in Europe where we have lots of first line options or even second line as switch, the association between dolutegravir and neural tube defects is significant, very, very low though, but significant when we are in a context where we have a lot of options. I would not put a woman who wants to conceive under dolutegravir because I have many more options. But if one of my patients is conceiving while she is on dolutegravir, then I will definitely not switch during the first trimester, because we know that if there is that the impact of dolutegravir on the neural tubes, it's really at the beginning of the conception, and usually when you diagnose a pregnancy, it's after a few weeks. So this very specific period is over, so there is no need to change treatment. But I would not put a woman on dolutegravir if she wants to conceive before the pregnancy. What's your opinion on that, Elizabeth?
I think I agree with you, Corinne. You've phrased it very well, very, very well.
Mm-hmm. What about you, Claudia?
Yes, absolutely. I totally agree with your position. Yes.
Okay. That's a question for you, Claudia, regarding the menopause and symptoms of menopause. Are HIV women experiencing more menopause symptoms? That's from Martin Drolet.
No, they're not getting more symptoms, but there is studies that reveal that that HIV women have menopause earlier. So at age that you are usually not expecting to have a patient with menopause, they have maybe 5 years before, 5 years before her mother, for example, or her sisters, they are getting menopause symptoms. And if we are not, if we don't know this, we are start thinking in another diagnosis. So we waste time and we start some preventions because we're not thinking about menopause in younger women. The symptoms are more or less the same, but you can, or the patient can be confused in terms of these are symptoms of the menopause, or these are symptoms of the new HIV treatment that I'm getting. So it's sometimes a little bit difficult when both things start at the same time. So you have to be clear. And of course, ID physicians, most of us, we are not very well aware about menopause treatment and how to deal with the symptoms. So that's where we need to ask for help with this. And we need, of course, to have a colleague and OB/GYN that really it's close to the HIV area, so he can support us effectively. And another thing I would like to mention is that we are starting, or in some places we already know how to deal with patients that have violent issues in their houses. But we usually think about that in young women, that they receive violence from her partners. But in older women, we don't put that in our list of concerns, but it's a very real concern. Many older women, actually some of them very old, get a lot of violence, physical violence in their houses. So we need to still keep attention to that possibility.
Okay, yeah, I also agree about what you said. And regarding the symptoms in older women with menopause, do you think that we should prescribe low-dose hormone therapy because it might be quite helpful on the symptoms and there is no drug-drug interactions with ARV? So would you agree on that, or do you think that there is some danger to prescribe replacement therapy?
Yes. Can you hear me?
Yes, you can. Yeah, go ahead.
Okay. No, hormone replacement therapy is not prohibited. You need to check, of course, and use this. For me, the best tool is the Liverpool Interaction webpage, and you can use it. The thing is that many of the ID physicians are not used to prescribe this kind of treatment, hormonal treatment. That's why you need to have a colleague that help you with this, but they're not contraindicated at all.
Yeah, and maybe a more general. A last question regarding menopause, and then I have a very interesting question about the role of women doctors. Last question on menopause: what caused the earlier menopause in HIV-infected women?
There's a not clear answer for that. There is something about the inflammation. That's a theory that this inflammation state can provoke an early menopause, but there is a not straight direction or publication that can explain the specific way why this is happening.
Okay. And maybe you can start on talking about that, Elizabeth, but then I think that this is a question for us all. Don't you think that the fact that only women physicians work on women and HIV is a signal of a problem? I don't know how it is in your context, but here in France, that's pretty much the fact that mostly women doctors work for women and HIV. So do you think that it's a signal of a problem? And if you think it is, how do you think that we should try to change that and change the view we have on the challenges of women living with HIV? Elizabeth, would you like to start with that?
Thank you, Karin. Well, in my country, it's not a problem in the sense that we do have male physicians working in this field of HIV and women. So it's not a women's only field, but perhaps because we still have many more doctors who are male compared to the women who are doctors, perhaps because we're still a developing country. But I would want to say that people will work on the things that is a passion for them. Now, as a woman, I do have a reason to work on women's health because it's something that impacts me and something that interests me. But for every man out there, they probably have a mother or a sister. If they're lucky, they may have a daughter. So they do have a reason why they would want to work in this field. So over to you, Karin, so that I give two of you a chance to also speak into this.
So what's your view, Claudia, very briefly?
It's an excellent answer. But I believe in France, probably in Chile, in many Latin American countries, and it's different in Africa, the amount of women with HIV are very few. We have, I don't know, 1 woman per 12 men. So, of course, women doctors are more close and they feel this connection with women because there are very few in my reality. So, of course, you try to help them have more connected. You see things a little bit more like a women patient than a colleague, a male colleague.
Okay, in any case, I've been myself very happy to share this virtual stage with you both. And I wanted to thank the International Workshop on HIV and Women to give us the opportunity to deliver those talks on women living with HIV. I of course, wanted to thank MSD for organizing this symposium. And I hope you enjoyed the talks and the Q&A session. And I wanted to say goodbye to you and have a good day. Thank you, Elizabeth. Thank you, Claudia. Thanks to everybody. Goodbye.
Bye.
Bye. Thank you. Take care.